Each of the following is a description of nitrous oxide except for one. Which one is the exception? Nitrous oxide does have many advantages, which make it a convenient substance for use in the dental clinic. It's a sedative that is used to reduce the anxiety of patients in the dental chair and is beneficial because it has a fast onset and is short-acting, and this just means that there's little downtime for recovery from the sedative. It's also fairly easy to administer, and no needles are needed, which may contribute to the ease of the procedure for the patient. It also does have a mild sweet odor, is non-flammable, and is colorless. So option C reads flammable, but as we know, nitrous oxide is not flammable, making it a relatively safe gas to keep around the clinic, so this answer is correct. However, while it is not flammable, it is still capable of contributing to combustion of other materials, so we do have to be aware of this when handling other chemicals or heat around nitrous oxide. Given this information, we also know that A is incorrect as it is a colorless gas, and remember, we're looking for the exception. Option B reads virtually odorless, and while nitrous oxide does have somewhat of a mild sweet odor, this is not an unpleasant smell for patients, and in most cases, it is virtually indistinguishable, making B an incorrect answer as well. Option D reads inorganic gas, and this is also incorrect as it is an inorganic gas. These are defined as chemicals that do not contain a carbon in their chemical structure. And as we can see here, nitrous oxide is just made of a nitrogen, 2 oxygens, and a hydrogen, so this is indeed an inorganic gas.
Question 1 asks which procedure is considered to have a moderate risk of bleeding. So, dental procedures typically have low risk bleeding. When a patient is taking an anticoagulant, regardless if the patient continues to use it or stops it before a procedure, bleeding rates are low. We see low bleeding when we administer local anesthesia, simple restorations, supragingival bleeding, and single tooth extractions. However, some have a moderate risk of bleeding. So we see this increased risk when we are doing an extraction of 2 to 4 teeth and when we perform a local general surgery of 5 or fewer teeth. So looking at our options, option A reads administration of local anesthetic. Just like we said before, this is a low risk, so this would be incorrect. Next is option B, simple restorations. Just like we said before, this is a low risk of bleeding, so this would be incorrect. Option C reads single tooth extraction. Again, just like we said before, this is a low risk, so this would be incorrect, leaving us with local gingival surgery of 5 or fewer teeth. We mentioned before that local gingival surgery of 5 or fewer teeth and an extraction of 2 to 4 teeth would be an increased risk, a moderate risk of bleeding, so this would be the correct answer.
Question 23 states, how much mercury vapor is released from each amalgam-filled tooth surface? Well, when looking at one amalgam-filled tooth surface, between 0.2 and 0.4 micrograms of mercury vapor per day is released. Looking at the tolerable mercury limit per day for an adult at about 130 pounds, the tolerable mercury is at about 5.8 micrograms per day. So we can cross off option choices C and D here. The reason for that is because option choice C is a little bit high, but still just under the tolerable mercury limit. Option choice D is way above the tolerable mercury limit, and it would not be allowed to be even used in dental practice. Option choice A is incorrect as it's a very small number, even smaller than the actual amount of mercury vapor released per day for one amalgam-filled tooth surface. But looking at option choice B, that is correct as it's right there between that range of 0.2 to 0.4 micrograms of mercury vapor released per day for one amalgam-filled tooth surface.
So question 74 asks, prescription of erectile dysfunction medication in patients using nitrates can result in which condition? So erectile dysfunction medications include phosphodiesterase 5 inhibitors, which prevent phosphodiesterase enzymes from breaking down CAMP and CGMP in the cell. So what this does is it causes smooth muscles to relax and vasodilation. So nitrates get broken down to nitrous oxide, and that also causes smooth muscles to relax and vasodilation. So option B reads hypoglycemia. This is low glucose in the body, and it is not an effective erectile dysfunction medication in nitrates, so this would be incorrect. Option C reads life-threatening hypertension, and this is caused by vasoconstriction, but erectile dysfunction medications and nitrates cause vasodilation, so this would be incorrect. Option D reads ocular hypertension, which could be caused by vasoconstriction, which is not an effect of erectile dysfunction medication and nitrates, so this would be incorrect. Leaving us with option A, life-threatening hypotension. So again, because erectile dysfunction medications and nitrates cause vasodilation individually, taken together, that would increase the effect, leading to life-threatening hypotension, so this would be the correct answer for this question. Also, remember, patients with angina shouldn't have nitroglycerin if they've used phosphodiesterase 5 inhibitors because it'll have the same effect and lead to life-threatening hypotension.
Question 28 states, which describes the measure of radiant power striking a specific area? Well, radiant exposure is defined as radiant energy received by a surface per unit area. So we can cross A off the list as it's not the definition we're looking for. Radiant excitance is the ability of a surface to emit radiation. So this is also not the definition we're looking for, and we can cross B off the list. Next, we're looking at D, radiant intensity, which is defined as the power per unit solid angle. So this is also not the definition we're looking for here, and we can cross D off the list. Lastly, we're looking at option choice C, irradiance, as a definition. So irradiance is defined as the radiant power striking a specific area. So that's our answer choice, C.
Question 14 asks, what is the minimum required filtration rate of a respirator? So the filtration rate is set by the Center for Disease Control and Prevention, the CDC, and these masks are evaluated, tested, and approved by the National Institute for Occupational Safety and Health. There are different types, and they all have the same filtration rate. It's important that they do so that large or small particles don't get in. Option A reads 90%, which is incorrect. Option C reads 99%, which has been approved by the NIOSH, but it is not the minimum required filtration rate, so this is incorrect. Option D reads 99.97, which has also been approved by the NIOSH, but it is not the minimum required filtration rate, so this is also incorrect, leaving us with option B, 95%, which is the minimum required filtration rate. We see it in N95s, R95s, or P95 respirators. They all filter 95% or more of large and small airborne particles, so this is the correct answer for So question 10 asks us, each of the following is the level of control for tuberculosis infection according to Centers for Disease Control and Prevention, the CDC, except one, which is the exception. So the CDC is an organization that provides leadership and promotes interventions to improve oral health at a community level. And they recommend that all dental care settings follow 3 levels of control for tuberculosis infection control. So these 3 levels of control for tuberculosis infection control include administrative control, environmental control, and respiratory protection control. So administrative control includes planning and assigning responsibility of TB infection control. So that includes instructing patients to wear masks if they're coughing, educating the dental health personnel in the office, screening for TB, and postponing non-urgent dental treatment if there is a suspected case. Environmental control includes using an airborne infection isolation room to provide urgent treatment to patients who are suspected or confirmed of infectious tuberculosis. We can do this by using air filters or ultraviolet germicidal irradiation. Respiratory protection control includes wearing masks like an N95 mask when treating patients who are suspected or confirmed for infectious TB, and instructing TB patients to cover their mouth when coughing or to wear a mask. So looking at our options, we see that option B is the administrative control, like we said before, so that would be incorrect since we're looking for a level of control that doesn't fall under the 3 that the CDC recommends. Next, we have option C, environmental control. Again, we mentioned it before, so that would be incorrect. Option D is respiratory protection control, and this is one of the 3 control levels that
Which is the most commonly used form of self-applied fluoride worldwide? Fluoride is an essential part of the at-home oral hygiene routine and is especially important in those who are at a high risk of developing caries. It does tend to be more essential in those who do not have accessibility to community water fluoridation. Enamel is constantly going through cycles of remineralization and demineralization, and when bacteria produce acid as a byproduct, this makes the enamel susceptible to decay as part of the demineralization process. Remineralization will occur when the pH returns back to normal after the consumption of carbs stop, and fluorides can prolong the duration of remineralization in order to prevent and reduce levels of decay. We want to have greater levels of remineralization compared to demineralization in order to prevent the development of decay. Taking a look at our options, we have option A, which reads fluoride toothpaste, and this is our correct answer as this is our most commonly used form of self-applied fluoride worldwide. In the United States, along with many other countries, toothpastes are fluoridated, and this helps with increasing fluoride levels in the oral cavity by 100 to 1,000 fold. If fluoride is present in the oral cavity during the process of remineralization, it will incorporate into the enamel and create a structure called fluoroapatite, which is beneficial as it is even more resistant to acid attacks compared to hydroxyapatite. The fluoride found in toothpaste can also directly promote remineralization and inhibit demineralization, and in some cases has also been shown to be bactericidal to cariogenic bacteria. Option B reads fluoride varnish, and this answer is incorrect as this is not a form of self-applied fluoride. This is a form of fluoride that is applied at the dental clinic by a dental professional. This is a resin-based product that typically contains high concentrations of fluoride and is found in the form of 5% sodium fluoride containing 2.26% or 22,600 parts per million of fluoride. Because it is a resin-based product, it is able to adhere to the hard tissues of the teeth and allow for continuous fluoride contact for an extended period of time. Option C reads fluoridated water, and this answer is also incorrect as this is not a form of self-applied fluoride. This is generally a type of community water fluoridation, and while it is on the responsibility of the patient to consume the source of fluoride, this is actually a form of systemic fluoride. Because it is ingested, it's incorporated into the tooth structure, making it more resistant to demineralization. And for the time that the fluoridated water is in the oral cavity, it can also provide some sort of protection in the form of topical fluoride and strengthen hard tissue structures. Option D reads fluoride gel, and this answer is also incorrect as this is not a type of self-applied fluoride. Like fluoride varnish, this is something that is applied by a dental professional, and it generally comes in the form of 1.25% acidulated phosphate fluoride, which is at a concentration of 12,300 parts per million, so half the strength of fluoride varnish. This does usually come in the form of a tray, which the patient will bite into for around 4 minutes, and it'll form a layer of calcium fluoride on the tooth, which can then act as a source of fluoride release into the oral cavity over time. So this question is asking about self-applied fluoride, and we know that fluoride toothpaste is one of them, and some other commonly used forms of self-applied fluoride are mouth rinses and some gels. And another type of fluoride that we're looking at is professionally applied fluoride, and in this category is fluoride varnishes, fluoride gels, but we also have fluoride foams and silver diamine fluoride as a type of professionally applied fluoride.
Question 113 reads, each of the following is a most likely sign of potential aspiration except one, which is the exception. So aspiration refers to the accidental breathing in of a food, fluid, or in this case, a crown into the lungs. It's really dangerous because it can cause the patient to choke, so it's really important that you know the signs that it's happening. So option A reads tachypnea. So this is breathing really fast, and it can happen when someone has accidentally swallowed something, and it could also be because of anxiety or other medical conditions. So because this is a sign of potential aspiration, this is incorrect. Option B reads coughing, and coughing is a clear sign of someone who might be choking on something that they aspirated. So again, this is incorrect. Option D reads cyanosis, and cyanosis is due to deoxygenated blood, and it's when you have bluish discoloration of your skin, nails, lips, or around the eyes. This is caused by not getting enough oxygen, which might be because of a patient who can't breathe properly because they're choking on something. This tells us that they aspirated something like a crown, so this is incorrect. Leaving us with option C, which is bradycardia. Bradycardia is a slower than normal heart rate, and this can happen due to several different medical conditions or medications, but not necessarily when it comes to aspiration, so this is not true, making this the correct answer for this question. So besides the signs that we mentioned before, low oxygen saturation, rhonchi or a whistling sound when breathing, rales or a crackling sound when breathing, or the absence of breathing sounds are all other signs of aspiration of a foreign object. A patient who develops a fever, chest pain, or difficulty swallowing are also other signs. So to test if a patient has aspirated an item, you can do a chest x-ray so that you can see if there is something in their airway. So question 9 reads, each of the following is an adverse health effect of nitrous oxide when chronically exposed except one, which is the exception. So nitrous oxide is an inhaled gas that's used in majority of dental clinics around the world to help relax anxious patients and relieve some of their pain. It's safe, but it can cause some health effects if a patient is chronically exposed to it. So option A reads infertility. So nitrous oxide is a pregnancy category C medication, meaning it does cause a risk of fetal harm for pregnant patients. So pregnant patients and staff should actually avoid being exposed to nitrous oxide because of the risk of infertility. So this would be incorrect. Option B reads blood dyscrasias. So nitrous oxide irreversibly inactivates vitamin B12, and it can cause a dose-dependent increase in plasma homocysteine concentrations. Patients who use nitrous oxide for a long period of time can develop blood dyscrasias like megaloblastic anemia, so this is incorrect. Option D reads neurologic deficits. So nitrous oxide can cause neuropathy, myelopathy, or subacute combined degeneration of the spinal cord, which is a complication of vitamin B12 deficiency, which we already know nitrous oxide causes. So this is incorrect. Leaving us with option C, emphysema. So emphysema is a lung condition that's caused by damaged or enlarged air sacs of the lung. It's not caused by chronic exposure to nitrous oxide, so this would be the correct answer for this question. So question 18 asks, each of the following are maternal risk factors for development of tetralogy of Fallot except one. Which is the exception? So tetralogy of Fallot is the congenital conotruncal abnormality caused by improper neural crest migration during cardiac embryology development. It causes low oxygen blood to flow out of the heart and into the rest of the body, and it's characterized by four key abnormalities of the heart: pulmonary stenosis, overriding aorta, ventricular septal defect, and right ventricular hypertrophy. There are several risk factors for the development of tetralogy of Fallot in a newborn, but this question is asking for the one that isn't. So option A reads maternal alcohol use. Alcohol exposure in utero and fetal alcohol syndrome are known risk factors for tetralogy of Fallot. So this can lead to other things like ventricular septal defect, atrial septal defect, and patent ductus arteriosus. So this is incorrect. Option B reads maternal obesity. Maternal obesity and maternal malnutrition are also known risk factors for tetralogy of Fallot. So this is incorrect. So option C reads advanced maternal age. So advanced maternal age, or having a baby at an older age, especially over the age of 40, is a risk factor for tetralogy of Fallot. It's also associated with an increased risk of chromosome abnormalities like Down syndrome, which are also then further linked to the development of tetralogy of Fallot. So this is incorrect. Leaving us with option D, maternal rubella vaccination. So although rubella has been linked to tetralogy of Fallot, its vaccination hasn't. So this makes it the correct answer for this question. So question 32 asks, what could be prescribed to counter the symptoms the patient is experiencing? Here we have a 45-year-old male patient. His chief complaint is, I've been developing a lot of canker sores and hurt. His background and patient history is Behçet's disease. His current findings are inflamed erythematous and painful aphthous upper right buccal mucosa. So option A reads fluconazole. Fluconazole is an antifungal agent. It would not be used to treat an aphthous ulcer, so this would be incorrect. Option C reads diphenhydramine or Benadryl. This is an antihistamine, which we do use for hay fever, allergies, or colds, but not for aphthous ulcers, so this would be incorrect. Option D reads nystatin, which is an antifungal agent, and again, we don't use antifungal agents to treat aphthous ulcers, so this would be incorrect, leaving us with option B, dexamethasone, which is a corticosteroid that relieves inflammation and pain associated with aphthous ulcers. So this patient has Behçet's disease, which includes symptoms like red painful eyes, acne spots, and headaches, but they also experience ulcers in the oral cavity, just like in this visual that we see here, and that can be treated with corticosteroid mouth rinses like dexamethasone. So this would be the correct answer. Question 111 reads, which is the most appropriate treatment? So here we have a 42-year-old female patient. Her chief complaint is my tooth hurts when I bite sometimes. Her current findings include an upper right second premolar that shows a crack along the central groove extending to the upper middle third of the lingual wall and normal cold and percussion sensitivity. So it's important to note that this patient has a cracked tooth with minimal extension. So that means that the entire tooth or majority of the tooth is not affected and there's no pulp or root involvement. So option A reads root canal treatment. So this is incorrect because, like we said before, there's no pulp involvement. So we wouldn't do a root canal because root canals are only done once the pulp is involved, making this incorrect. Option B reads extraction, and we would only do this if the tooth was unrestorable, but in this case it is, so this is incorrect. Option D reads no treatment. The patient is clearly in pain and has a cracked tooth, so this needs to be treated before it progresses into something even more severe. So this is incorrect. And that leaves us with option C, cuspal reinforced restoration. So like we said before, the patient has a cracked tooth that's only reaching the middle third of the lingual wall, and there's no pulp or root involvement. So that means that this tooth is restorable, and it's important that you treat it because you don't want it to progress into something more severe. So in this situation, in simple terms, you would remove the crack and cover it with the restoration material, which is what cuspal reinforced restoration is. So this is the correct answer for this question. Question 110 reads, what is the most appropriate next step? So here we have a 70-year-old male patient. His chief complaint is, I'm here to get my tooth taken out. His background and patient history reads type 2 diabetes, history of myocardial infarction 10 years ago. His medications include metformin, hydrochlorothiazide, and aspirin, and his current findings are a blood pressure reading of 132/82 and non-restorable mandibular left first molar with extensive caries and periapical pathology. So based on the patient's history, we see that they have a history of myocardial infarction 10 years ago. That's very important to know. So option 8 reads discontinue aspirin the morning of the appointment. So the patient is taking aspirin to prevent blood clots that could lead to an embolism. And if you stop the aspirin, you're putting the patient at a very dangerous risk of developing those blood clots. So this is incorrect. Option B reads obtain an INR level the morning of the appointment. So aspirin affects bleeding time, but it doesn't affect INR, platelet time, or prothrombin time. So this is incorrect. Option C reads use local anesthesia with 1 to 50,000 epinephrine for hemostasis. When it comes to patients with cardiovascular complications, you would only do this when it is absolutely needed to control blood flow. You need to use it with caution and not use more than one cartridge in patients with cardiovascular disease, like this patient. So because this is not needed, this is incorrect, leaving us with option D, proceed without treatment modification. So like I said before, if you stop aspirin, you can put the patient at risk of an embolism. So it's best that the patient continues to take the medication through the surgery. So this is the correct answer for this question.
Each of the following is included in the bloodborne pathogens guideline except for one. Which one is the exception? This guideline is mandated by the OSHA or the Occupational Safety and Health Occupation, which aims to protect employees from dangers in the workplace. The goal of this specific guideline is to protect employees from bloodborne pathogens and potentially infectious diseases. We know generally that the 4 basic requirements of the bloodborne pathogens guideline includes exposure control plans, engineering and work practice controls, hazard communication and training, and requiring the hepatitis B vaccination. So because of this, we know that D is an incorrect answer as it is included in the guideline. The reason that it is included is because it's a bloodborne pathogen and because the risk of transmission prior to vaccination is 30%, but after receiving vaccination, the risk of transmission after percutaneous injury falls significantly. So option B reads hepatitis C, and this answer is also incorrect because this is a bloodborne disease as well. However, the transmission rates are only 1.8% following exposure, and here there is no current vaccination, so it is not mandated in the guideline to get the vaccination. However, it is still included as an infectious disease, so we do have to follow all protocols in order to prevent transmission of this. One thing to consider is that not all hepatitis cases are included in the bloodborne pathogens guideline, as not all hepatitis cases are transmitted through blood. So as we can see here, it is the case for hepatitis B and hepatitis C, which is why they are included, but for the others, they are transmitted through other means such as fecal-oral transmission or through direct contact with bodily fluids. Option A reads human immunodeficiency virus, and this is more commonly known as HIV. There is no vaccination available for treatment, but the risk of transmission after exposure is only 0.3%. However, since this still is a bloodborne pathogen and there still is a risk of life-threatening illness following exposure, it is included in the guidelines. There's also an antiretroviral therapy treatment that needs to be taken within 72 hours following exposure, and this will help dramatically reduce the risk of transmission even more. This means that C is our correct answer, as herpes is not included in the bloodborne pathogens guideline. So this includes herpes simplex 1 and herpes simplex 2. The former usually causes oral herpes, and the latter is the cause of genital herpes. But like I mentioned, these are not spread through blood, but are usually spread through skin-to-skin contact, which is why they are not included in the bloodborne pathogens guideline.
So question 16 reads, which is the most appropriate treatment? So in the question, we have a 35-year-old female patient whose chief complaint is, I've had my tooth removed a few days ago and now my jaw hurts and my mouth smells. Her background and patient history is an upper left second premolar extracted 2 days ago, and in her current findings, she has no swelling but exposed bone in the extraction site. So given that she's had an extraction done a few days ago, and now that her jaw hurts and there's exposed bone in the extraction site and a smell, this all indicates alveolar osteitis, also called dry socket. So we know dry socket is when a blood clot at the extraction site fails to develop or is dislodged, so interrupting complete healing. It's important that a blood clot develops because it serves as a protective layer that covers bone and nerve endings and is the foundation of growth for new bone in soft tissue. When treating dry socket, you want to flush the socket with a saline rinse and place a medicated dressing that has an antibacterial and topical anesthetic like zinc oxide eugenol or lidocaine at the site, and prescribe pain medication. It's also important to remember that medicated dressings prolong healing, so it's important to remove that once the pain has lessened. So looking at our options, option A is a saline rinse and curette. So while we do add saline rinse, we don't want to curette the site because it would only cause more pain to the patient and remove healthy tissue, which is important for proper wound healing, making this incorrect. Option B says no treatment necessary, which would be incorrect because we obviously want to treat the patient's pain and help ensure proper healing. Option D says curette only. Again, we don't want to curette just like we said before, so this would be incorrect, leaving us with option C, saline rinse and zinc oxide eugenol dressing, which is the correct treatment for dry socket, making this the correct answer. So question 65 reads, what is the most likely ASA classification for an uncontrolled diabetic? So the ASA classification system is used to help assess a patient's physical status and preoperative risks. Option A reads ASA 1. This classification is for healthy patients who do not smoke or drink little to no alcohol, so this would not be the case, making this incorrect. Option B reads ASA 2. This classification is for patients with a mild systemic disease that doesn't cause any functional limitation, so that would include controlled diabetes and hypertension, obesity, and mild lung disease. It also includes pregnancy, smoking, and social alcohol drinking. So since we're looking for uncontrolled diabetes, this would be incorrect. Option D reads ASA 4. This classification is for patients with severe systemic diseases that are a constant threat to life. This includes myocardial infarction, cerebrovascular accidents, ongoing cardiac ischemia or severe valve dysfunction, sepsis, DIC, and end-stage renal disease, but not undergoing regularly scheduled dialysis. So this would be incorrect. Leaving us with option C, ASA 3. This classification is for patients with a severe systemic disease that causes functional limitations, and this can include poorly controlled diabetes, hypertension, chronic obstructive pulmonary disease, morbid obesity, hepatitis, alcohol abuse, and end-stage renal disease, but with regularly scheduled dialysis. So considering this question is asking us about uncontrolled diabetes, that falls under the classification of ASA 3, making option C the correct answer for this question. So question 13 reads, which is the most appropriate antibiotic prophylactic option? So we know we administer antibiotic prophylaxis before invasive dental procedures, usually to prevent infective endocarditis. So we do antibiotic prophylaxis for patients who have a history of endocarditis, prosthetic cardiac valves or other prosthetic materials for valve repair, cardiac transplants with structural valve abnormality, and other forms of congenital heart disease. So here we have a male patient. His chief complaint is, I'm here for an extraction. His background and patient history reads hypertension, deep vein thrombosis, gastroesophageal reflux disease or GERD. So after reading our patient box, we understand our patient isn't suffering from any of the conditions that indicate antibiotic prophylaxis. So looking at our options, option A reads amoxicillin, which is incorrect because we do not need to do antibiotic prophylaxis. Next is option B, clindamycin. Again, incorrect because no antibiotics are indicated. Also, remember, clindamycin is no longer recommended for prophylaxis, so this is incorrect. Option C is azithromycin, which is again incorrect because we do not need to administer antibiotic prophylaxis, leaving us with option D, no antibiotics indicated, which is true considering his background and patient history. So this is the correct answer for this question.
Which is the fluoride concentration of prescription strength fluoride toothpaste in the US? Fluoride toothpastes are one of the most commonly used form of self-applied fluoride products in the world. The use of fluoride is essential in the preventative oral hygiene routine as it can help with remineralizing enamel and it can reduce the amount of demineralization that can occur. And what this means is that it makes the tooth more resistant to acid attacks and therefore more resistant to decay. Regular over-the-counter fluoride toothpaste are found with fluoride concentrations of around 1,000 to 1,100 parts per million. So obviously, prescription toothpaste would contain a much higher amount. Our correct answer is A, which reads 5,000 parts per million, and these toothpastes that contain this level of fluoride are only available by prescription. So to put this into perspective, a fluoridated community water has around 0.7 parts per million fluoride, and then we find regular fluoridated toothpaste at a higher concentration, and then finally we have these prescription strength toothpastes. So let's take a look at our other answers. Option B reads 10,000 parts per million, and this answer is incorrect as this is almost double the strength of prescription strength toothpastes. Generally, toothpastes do not come in this high of a fluoride concentration as there are concerns with fluorosis in younger patients with developing teeth. While fluoride toothpastes do not contain anywhere near 10,000 parts per million of fluoride, fluoride gels that are applied at the dental clinic can contain anywhere from 5,000 to 12,300 parts per million. So 10,000 parts per million of fluoride falls within this range. Fluoride gel is placed into a disposable tray and placed into the patient's mouth for a few minutes, and this will help with remineralizing incipient lesions and preventing further decay from occurring. Option C reads 20,000 parts per million, and this answer is also incorrect as prescription strength toothpastes do not contain this much fluoride. Instead, a product that has an amount that is more in line with this value is fluoride varnish. These are resin-based products that are applied to clean and dry teeth at the dental office and can stay on for a period of time, allowing for continuous release of fluoride. They serve the same purpose of fluoride gels and can remineralize incipient decay and prevent further decay from occurring. Option D reads 30,000 parts per million, and this answer is incorrect as this level of fluoride is too high for toothpastes. There aren't many commonly used products containing such a high level of fluoride, but the closest that we have are fluoride varnishes. Which class of drug is the most appropriate for oral sedation in an anxious adult patient? So we can have various types of sedation, starting with the most mild is nitrous oxide sedation, and this is completely conscious and used for those with mild to moderate anxiety. We can also have IV sedation and general anesthesia, which is used for those with severe anxiety and needing extensive work. And then in between these extremes is oral sedation, which is also a conscious type of sedation. And this is used for patients that have a more moderate to severe anxiety. It will involve using drugs like benzodiazepines and barbiturates, so this makes C the correct answer. And then although barbiturates can be used for oral sedation and can actually cause a stronger sedative effect, we don't really recommend this for use anymore due to the potential for toxicity because it is difficult to get the right dose, especially with oral sedation. It can cause issues like respiratory depression, hypotension, and vasodilation, and then in extreme cases, barbiturates can lead to coma or death. But on the other hand, benzodiazepines are the ideal drug for oral sedation because they have a wide therapeutic index and have a lower risk of respiratory depression. With calcium channel blockers, we know that this is an incorrect option because it's generally used for reducing hypertension as well as controlling chest pain and arrhythmias. How it works is that it will block calcium channels in the heart, and then once it's blocked, the heart and arteries can no longer contract as much, causing the blood vessels to dilate. So this answer is also incorrect. Finally, we have opioids, and these are generally only used if other analgesics are ineffective. And this can sometimes be used in adjunct with other sedatives, but it's generally used with another IV sedative and not with oral sedatives. And typically they are not used alone, as they don't actually cause a sedation or anti-anxiety effect. In addition, there is a huge risk of respiratory depression with opioids, so it's generally uncommon to use as an oral sedative.
So question 34 asks, what is the next best step? Here we have a 35-year-old female patient. Her chief complaint is there is a bump on my gums that is bothering me. Her background and patient history is that she gave birth 1 month ago and the lesion has been present for about 6 months. Her current findings are a raised, round, pedunculated red lesion that is 7 millimeters in diameter on the interdental gingiva between the upper right lateral incisor and canine. So, considering the lesion appeared during her pregnancy and it's on the interdental gingiva, it's also red, circular, and raised, this leads us to think it's pyogenic granuloma. So these lesions are caused by minor trauma or altered hormones like during pregnancy. So they share the same characteristics in the patient box and they look similar to the lesion in this image. They're usually 1 centimeter in diameter and they can also appear on the lower lip, tongue, and buccal mucosa. They also ulcerate and bleed easily. So here are the questions asking us, what do we do next? Option A reads, prescribe nystatin, mouth rinse, and monitor. So this would be useful in a fungal infection like candidiasis. However, this is not a fungal infection, so this would not treat pyogenic granuloma, so this would be incorrect. Option B reads, aspiration lesion. So aspirational biopsies are used for fluid-filled or intrabony lesions. This is not descriptive of pyogenic granuloma, so this would be incorrect. Option C reads incisional biopsy. So these are appropriate for lesions that are larger than 1 centimeter, and since this lesion is 7 millimeters, this would be incorrect. Option D reads excisional biopsy. So these biopsies are recommended for lesions that are smaller than 1 centimeter, just like this one in this case, so that would be the correct next step, and thus the correct answer for this question. Question 6 asks, during the oral examination, the dentist noticed that the patient begins breathing abnormally, emitting a fruity smelling breath. What is the most likely cause of these new symptoms? So immediately, the hint, fruity smelling breath, should give you a good idea of what the answer is, but let's break down the other options first. So option B reads hyperventilation. So hyperventilation is also characterized by abnormal breathing, but not fruity breath. So this would be incorrect. Option C reads non-allergic asthmatic attack. So this is also called intrinsic asthma, and it's actually a more dangerous type of asthma that's not caused by an allergy in comparison to extrinsic asthma, which is caused by an allergy. So it does also involve abnormal breathing, but it's actually more common in adults over the age of 35. So considering our patient's age and that fruity smelling breath, this tells us this is incorrect. Option D reads orthostatic hypotension. What this is it's a rapid decrease in blood pressure when a patient is moving from laying down to suddenly standing back up. So here your patient is going to feel dizzy and lightheaded, and we see this a lot with older patients. It's actually uncommon in infants and children, and it's not characterized by heavy breathing or a fruity smelling breath. So this is incorrect. Leaving us with option A, diabetic ketoacidosis. So this is a complication that we see in type 1 diabetics, and it's characterized by fruity smelling breath because of increased ketones in the body. This is because the cells are not able to use glucose, so there is increased lipolysis by the liver to produce keto acids as an alternative energy source. So that's where the fruity smelling breath comes from. The abnormal breathing is from the body's response to the keto acid accumulation. The body tries to give out carbon dioxide by fast and deep breath called Kussmaul breathing. So diabetic ketoacidosis is a major sign for type 1 diabetes. It's actually a diagnostic sign, making this the correct answer for this question. Question 81 reads, what is appropriate in the management of this patient's chief complaint? After considering the patient's complaint of pain, not being able to properly eat, the photograph that was shown to us of an ulcerated oral cavity, as well as the patient undergoing radiotherapy, we can assume that the patient has oral mucositis. So oral mucositis is tissue swelling and irritation in the mouth, and it is the most common complication of oral cancer treatments, specifically chemo and radiation. So your patient will have erythema, pain, ulcerations, and edema of the oral mucosa. So here our question is asking us, how do we manage this? Option A reads antimicrobial lozenges. So there hasn't been enough real evidence of lozenges having an effect on oral mucositis, so that would make this incorrect. Option B reads chlorhexidine. So there has been conflicting evidence for chlorhexidine having any healing properties for oral mucositis. Also, a lot of chlorhexidine mouthwashes have alcohol as an ingredient, and that can dehydrate and irritate the oral tissues even more. So this is incorrect. Option D reads dapsone. So dapsone is an antibiotic and anti-inflammatory drug, and we use it to treat leprosy, and you can also treat cutaneous disorders like pemphigoid or recurrent aphthous ulcers, but it's not used to treat oral mucositis, so this would be incorrect. Leaving us with option C, cryotherapy. So what is oral cryotherapy? This is a local cooling of the oral mucosa by using ice chips. And this can be done as a prophylaxis or treatment to help decrease the oral mucositis. How it works is that the coldness of the ice chips causes vasoconstriction, and that decreases the amount of mucotoxic agents that the cells are distributing. The cold temperature is going to actually lower inflammation from the radiation, and it's going to help bring down cell damage and ulceration. So this would be the correct answer. Also, you want to make sure if you see a patient like this that they keep up with good hygiene, analgesics, non-medicated oral rinses like saline, and also diet modifications to help with their oral mucositis. So question 2 asks, what international normalized ratio, or INR value, should patients have prior to their dental extractions if they want to continue the regular warfarin regimen? So before we tackle this question, let's remember what warfarin even is. Warfarin is a traditional oral anticoagulant drug, and it's prescribed to people who experience deep vein thrombosis, pulmonary embolism, MI, cardiac stent placement, or those with non-valvular atrial fibrillation. So INR is a calculation based on prothrombin time results, and a normal INR would be 1.1 or below. For those who take warfarin, it would be 2 to 3, and so having an INR of 3 or less would allow warfarin patients to continue their normal regime before a dental extraction. So for this question, we're looking for something that would follow the rule of 3 and below. So for option A, it reads 2 or less, which is not 3 and below, so that would be incorrect. Option B reads 2.5 or less, which again is not 3 or less, so that would be incorrect. Option D reads 3.5 or less, which is actually more than 3, so that would be too high and is incorrect, leaving us with option C. Option C reads 3.0 or less, which is exactly the value that we need, so this would be the correct answer. So question 61 reads, what is the most appropriate next step? So here we have a 28-year-old male patient. His chief complaint is yesterday. His background and patient history is that the patient fell down the stairs and hit his front tooth yesterday, no other injuries. His current findings are his upper right central tooth, no tooth structure is missing or broken. It appears elongated, tender to percussion, and has a class 2 mobility. Radiographically, a widened periodontal ligament is noted. So considering this patient's current findings and how it describes that the tooth appears elongated and it's mobile, and that the periodontal ligament appears elongated, we go ahead and assume extrusive luxation. So option A reads no treatment. Not treating this case can actually lead to even more trauma to the tooth and then eventually permanent tooth loss. So this mode of treatment could be appropriate for a concussed tooth, where you would just monitor the tooth but not for extrusive luxation, so this would be incorrect. Option B reads reposition and stabilize with rigid splint for 2 weeks. Using a rigid splint prevents physiologic movement of the tooth, and that can actually lead to ankylosis and external resorption, so this would be incorrect. Option D reads initiate endodontic therapy. The tooth is tender to percussion, meaning it's giving a positive response. If the tooth later develops a necrotic pulp, endodontic therapy can be indicated, but that's not the case right now, so this would be incorrect. Leaving us with option C, reposition and stabilize with flexible splint for 2 weeks. So in cases of extrusive luxation, you want to check the bony socket, and if it's intact, you stabilize the tooth with a flexible splint, similar to this image right here. And then you would schedule a follow-up and removal after 2 weeks, then monitor the pulp status after 4 weeks, 6 to 8 weeks, 3 months, 6 months, and then every year. So this would be the correct answer for this question.
Question 16 states, which material should an orthodontist be concerned with while bonding the brackets? The patient box just provides us with some information on why the patient is visiting the orthodontist's office. Let's look at the different answer choices, starting with mercury. Well, when we're looking at mercury, we're looking at dental amalgam, but dental amalgam isn't going to be relevant to orthodontic braces. Even though dental amalgam plus heat can lead to mercury vapor, it's still not something to be concerned of with regards to orthodontics. So we can cross this off the list. Next, we're going to look at arsenic. Arsenic is not going to be a component of orthodontic braces, so we can also cross this off the list. Finally, we're going to look at stainless steel. Stainless steel is not a health threat to the body, so this is something that can also be crossed off the list. What about bisphenol A? Well, bisphenol A is going to be relevant to the process of polymerization. So polymerization while using resin-based restorative materials can lead to monomers being released, and these monomers can be unreacted as a result of different factors such as oxygen acting as an inhibitive agent. And so in situations like this, BPA or bisphenol A can be released. And so a couple of different things can be used to ensure that BPA is not ingested or that much of a harm to a patient. The first thing is to use a glycerin-based product, and the second thing is to ensure that a patient rinses their mouth. So that leaves us with option choice B, bisphenol A, as the correct answer choice here.
Which is the most appropriate mechanism by which fluoride strengthens enamel? To answer this question, we have to know about how dental caries are formed. When carbohydrates are consumed, they act as a source of food for bacteria. When these carbohydrates are metabolized by the bacteria, acid is produced and can eventually demineralize tooth structure, specifically enamel. Demineralization of normal enamel, which contains around 97% hydroxyapatite, will occur at around 5.5. However, if fluoride is present in the oral cavity in the form of topical fluoride or systemic fluoride, this changes. Hydroxyapatite is composed of calcium and phosphate. If fluoride is present in the oral cavity, it can combine with the calcium and phosphate to create what is known as fluoroapatite. This occurs because it replaces the OH ion in hydroxyapatite with a fluoride ion. Fluoroapatite is beneficial because when it is present in the enamel, it is more resistant to acid attacks from bacteria and reduces enamel solubility. In fact, while demineralization takes place in hydroxyapatite at a pH of 5.5, the pH must be much more acidic at a level of 4.5 in order to demineralize fluoroapatite. So based off of what we know that options C and D are incorrect, as fluoride does not use carbohydrates to create fluoroapatite or hydroxyapatite. Instead, carbohydrates are used by bacteria to proliferate and create an acidic environment. Option B is also incorrect. It reads that fluoride combines with calcium and phosphate to make hydroxyapatite, but we know that hydroxyapatite is already present in enamel and makes up 98% of enamel and is composed of calcium and phosphate only. So this makes A our correct answer, as fluoroapatite is created when fluoride is present in the oral cavity and replaces the OH group in hydroxyapatite in order to form fluoroapatite. What is the appropriate concentration of acidulated phosphate fluoride? Acidulated phosphate fluoride, also known as APF, is an example of a form of topical fluoride. This is one that has an extremely high concentration of fluoride and requires a health practitioner for application of this product. Other forms of topical fluoride include the at-home use of toothpaste and mouthwashes, as well as the prescribed versions of these. We also have fluoride gels, varnishes, and foams, which are indicated here in red to show that professional application is required for these. We know that for the most part, toothpaste and mouth rinses that are purchased over the counter do have a low concentration of fluoride, and they can range from 1,000 to 1,500 parts per million, which is roughly equivalent to 0.24% sodium fluoride. With mouth rinses, daily sodium fluoride rinses can contain 0.05% fluoride ion, but higher concentrations of fluoride mouth rinses can also be found. For example, professionally applied rinsing solutions have 0.9% fluoride ion. This makes A our incorrect answer, as 0.9% is more accurate for professionally applied oral rinsing solutions rather than acidulated phosphate fluoride gel. In addition, some professionally applied fluoride foams and gels are also found to have the same percentage of fluoride, and these are loaded into trays, and the patient is meant to bite down on mouth trays for around 4 minutes. Option B reads 1.23%, and this is our correct answer, as this is the percentage of fluoride ion that is found in acidulated phosphate fluoride. This is also something that is applied by a dental professional, so same with the foams and gels, APF does also come in these forms, and it's applied in the same method. And this is just a stronger version of these sodium fluoride foams and gels that we typically use. And the benefit of APF over sodium fluoride gels is that it is acidic, as the name suggests. What this means is that the fluoride can reach the enamel at a faster rate, but it does also come with risks, such as damage to composite and ceramic restorations, leading to staining and reduced longevity due to the acidity of the solution. So option C reads 2%, and this answer is incorrect, as there are no products that contain 2% fluoride ion. Sodium fluoride gels or foams are found in 2% sodium fluoride formulations, but this is not to be confused with the fluoride concentration. The equivalent of 2% sodium fluoride formulations is 0.9% fluoride ion, as we can see here. Last, we have 2.26%, which is incorrect, as this is not the percentage of fluoride that is found in acidulated phosphate fluoride gels or foams. Instead, this is the amount of fluoride ions that are found in professionally applied varnishes. This product does have a high concentration of fluoride, and so professional application is required. And the use of this every 3 to 6 months has been shown to prevent caries in adults. Fluoride varnish is also a great tool for children under the age of 6 who are at high risk of decay, because unlike foams and gels, there's a low risk of accidental ingestion of fluoride, which can lead to fluorosis or acute toxicity in some rare cases.
Question 22 reads, 15 minutes into the procedure, the patient grabs his chest and states that his jaw is hurting. He then reports a pain radiating down his left arm and acute weakness. The dentist reaches to check the patient's pulse and notices that the patient is diaphoretic. The dentist rechecks the blood pressure, which now reads 85/65, with the pulse now at 112 beats per minute. Once EMS has been contacted, what is the next appropriate best step? Based on the symptoms that our patient is experiencing, such as chest pain, jaw pain, the radiating pain down his left arm, and weakness, also the low blood pressure, sweating, and increased pulse, all leads to the diagnosis of myocardial infarction. So option A reads administer atropine. So atropine is an anticholinergic drug, and it's used in emergencies when a patient is bradycardic to help speed up their heart rate. But it doesn't do anything for myocardial infarction, so this is incorrect. Option B reads administer nitroglycerin. So this is a drug that you would give to help with relief. It works as a vasodilator to help with blood flow reaching the heart so that the heart doesn't need to keep putting in extra effort, and it ultimately helps with pain. We actually would give this after the treatment for MI, so this isn't the appropriate best next step, making this incorrect. Option D reads administer adenosine. We use this in emergencies to treat arrhythmias to slow down the heart in a supraventricular tachycardia. How it works is that it decreases the impulses that are fired into the sinus node, which are actually the ones that are responsible for contraction, so that it can help prevent impulses being conducted to the AV node. So this is incorrect. Leaving us with option C, administer aspirin. So we all know that aspirin is a non-steroidal anti-inflammatory drug, but it's also a blood thinner. And how it works is that it irreversibly inactivates COX-1. What that's going to do is it's going to stop the generation of thromboxane A2, which is then going to prevent clotting and ultimately MI. So this is going to be the correct answer for this question.
The role of mouthguards has been recognized by the ADA for its importance in prevention of oral facial injuries. It's recommended that these are used in contact sports or during recreational activities in which the oral facial contact is at risk of injury. So taking a look at the patient box, we can see that we have a 14-year-old female who's presenting with a chief complaint that her mouthguard does not fit anymore, and we can see a picture of it here. Clinical examination tells us that this is an ill-fitting mouthguard that is affecting her occlusion. So this case study aims to highlight the importance of patient education on first, the need for mouthguards, and second, the use of appropriate mouthguards. Having children wear mouthguards during contact sports during their younger years will aid in normalizing mouthguard use and maintaining heightened levels of protection over time. So if we take a look at our answers, we first have A, which reads custom made. And this is an incorrect answer, as this is a type of mouthguard that has been approved by the ADA. This is one of the most protective forms of mouthguards, as it is properly fitted with ideal retention that will offer protection from dental injuries as well as injuries to soft tissues. These must be made at the dental clinic with impressions being taken first. The mouthguard is formed either with a vacuum or pressure method, and the mouthguards are normally made of either ethylene vinyl acetate, polyolefin, or polystyrene polyolefin polymers. While these are the ideal form of protection, they are also the most expensive option. So the ADA also does support the use of other mouthguards that can serve the same purpose if made well and used correctly. So option C reads boil and bite, and this is also an incorrect answer, as this is one of the ADA approved mouthguards. These are also known as mouth-formed mouthguards, and they're made by placing the mold in hot water for 15 seconds, taking it out of the water, waiting for it to cool, and then placed in the mouth. The patient is to bite down and smooth out the edges with either their tongue, fingers, or lips. These are advantageous compared to the custom ones, as they are fairly easy to access and considerably more affordable. However, if we take a look at this picture here, we can see the boil and bite mouthguard on the left and a custom-made one on the right. It's clear that if a person has a shortened dental arch or specific features that don't fit into the mold, the mouthguard may become difficult to wear, have poor retention and function, and then the patient may end up not wanting to wear it at all, leaving them susceptible during contact sports. Option D reads stock, and this is also incorrect, as this is another option that is recommended by the ADA. It is also known as a ready-made mouthguard, and these are the most commonly available out of the three that we have mentioned, as well as the most affordable option. These do come in a limited range of sizes, and the greatest disadvantage of this product is that the user's mouth needs to be shut in order to keep the mouthguard in and effective. And what this essentially means is that this mouthguard has poor retention and is likely an improper fit in most cases. However, it is better than no mouthguard at all when it comes to protection of the oral cavity during contact sports. Option B reads vulcanized, and this is our correct answer, as this is not a type of mouthguard that is recommended by the ADA. In fact, this is not a type of mouthguard at all. Instead, it refers to a process in which rubber is mixed with sulfur and heated in order to become a hardened material, and this can be used in denture fabrication.
Question 64 asks, which factor will most likely increase the risk of implant failure? So option A reads age. Age actually doesn't affect implant healing or overall prognosis. So for example, this patient being 73 years old doesn't have an effect on their prognosis. So this would be incorrect. Option B reads hypertension. Hypertension doesn't have an effect on implant healing, so this would be incorrect. Option D reads arrhythmia. Just like hypertension and age, heart arrhythmias don't affect implant healing, so this would be incorrect, leaving us with option C, diabetes. So remember, diabetes is a chronic health condition that affects how the body creates energy from food. Diabetic patients are unable to transport glucose from their blood into their cells because of insulin resistance or because of a lack of insulin from the pancreas not being able to produce any. So diabetes also affects healing, and this can be a problem when placing an implant in bone. So diabetes actually slows down blood circulation and makes blood more viscous. So that's going to cause less blood to go to the wound site, making a decrease in nutrients. So overall, this would lead to an increase in complications like infection. So all these side effects make uncontrolled diabetes a contraindication. And remember, HbA1c below 5.6 is normal, 5.7 to 6.4 is pre-diabetic, and above 6.5 is diabetic. We see uncontrolled diabetes if the HbA1c is above 8%, and that's when it's a contraindication for implants. Remember, this patient has an HbA1c of 8.7, which is too high. That's uncontrolled diabetes, and they would require a referral to their physician. Besides uncontrolled diabetes, immunocompromised patients, bruxism patients, and patients who use tobacco are also contraindicated for implants. So to wrap this all up, uncontrolled diabetes, just like we see in this patient, would be an increased risk for implant failure, making option C the correct answer for this question. Question 20 reads, each of the following is a recommendation for management of dental extraction in patients receiving bisphosphonate therapy for treatment of osteoporosis except one. Which is the exception? So osteoporosis is a disease where there is a discrepancy between bone resorption and formation. So osteoclasts are breaking down the bone faster than osteoblasts are able to build. This creates low bone density and puts patients at a higher risk for fracture. Bisphosphonates are drugs that work to decelerate the rate that osteoclasts break down bone, so it allows for osteoblasts to catch up and build. This mechanism may lead to medication-related osteonecrosis of the jaw, which is bone necrosis due to an extreme reduction of bone remodeling because of the osteoclast function that has been reduced. So when managing a patient who's using bisphosphonates, you want to make sure you administer conservative surgical techniques, primary closure when possible, place a semi-permeable membrane when primary closure is not achievable, and chlorhexidine rinses before and after treatment. So remember, when answering this question, we want to look for an option that is not recommended for management of bisphosphonate patients. Option A reads conservative extraction techniques. Just like we said before, conservative extraction techniques are recommended, so this would be incorrect. Option B reads chlorhexidine rinses before and after surgical treatment. Again, this is a recommended method when treating patients receiving bisphosphonate therapy for osteoporosis, so this would be incorrect. Next is option D, semi-permeable membrane placement in the absence of primary closure. Again, we mentioned this before, so this would be incorrect, leaving us with option C, 6 to 8 months bisphosphonate cessation prior to surgical treatment. There is not enough evidence currently that suggests 6 to 8 month drug holiday before extraction for patients with osteoporosis is beneficial. So because this is not one of the recommendations for management, this would be the correct answer. So question 6 asks, what is the primary cause of duodenal ulcers? So option A reads ibuprofen, which is a non-steroidal anti-inflammatory drug. We know that ibuprofen blocks prostaglandin production because it inhibits COX-1 and COX-2. Prostaglandin actually protects the gastric mucosa by inhibiting acid secretion. So when it's blocked, the gastric linings in the stomach or duodenum are not protected and can become damaged and ulcerated. So while yes, it is a cause of duodenal ulcers, it is not the primary cause, making this incorrect. The word primary is really important to remember when answering this question. So option C reads acetaminophen. Acetaminophen is not likely to cause duodenal ulcers because it doesn't affect the gastric lining, so this would be incorrect. Option D reads chronic alcohol consumption. Now, alcohol consumption may irritate and damage the lining of the stomach and duodenum and cause gastritis and ulceritis, but it's not the primary cause, so this would be incorrect. Leaving us with option B, Helicobacter pylori, or H. pylori. H. pylori is a gram-negative microaerophilic spiral bacteria that infects the stomach and can cause damage to the lining of the stomach and duodenum in the form of ulceration and inflammation. Patients who have H. pylori infection have signs and symptoms such as stomach pain that gets worse when the stomach is empty, loss of appetite, or bloating. You can even be asymptomatic. So the treatment is antibiotics. H. pylori is the primary cause of duodenum and stomach ulcers, so this would be the correct answer. Question 9 reads, which of the following is a symptom indicative of active tuberculosis? So active tuberculosis is a disease caused by the bacteria called Mycobacterium tuberculosis, and it can attack any part of the body, but it usually attacks the lungs. And it's accompanied by the following symptoms: coughing for more than 3 weeks, chest pains, fatigue, fever, hoarseness, night sweats, unexplained weight loss, and hemoptysis, which is coughing up blood from the lungs. So after learning our symptoms, we look at our options that are given. So option A reads hair loss. Hair loss is not a symptom of active tuberculosis, and that makes it incorrect. Next, we have option B, or weight gain. So we know that in active tuberculosis, we see unexplained weight loss. So that would make this option incorrect. Next is option D, dysphagia, which is a difficulty in swallowing, and we know that's not a symptom indicative of active tuberculosis, so that makes option D incorrect. So this leaves us with option C, hemoptysis, or coughing up blood from the lungs, which is a symptom seen in active tuberculosis, like we mentioned before, and that makes option C correct. Oral manifestations of active tuberculosis are also important to remember, so that includes ulcers, tuberculosis osteomyelitis, and scrofula.
How often should biological monitoring or spore testing be done? So we know that this question is asking about spores, and this means that it is referring to the sterilization process, as sterilization is the only method of decontamination that is able to kill bacterial spores. What a spore test will do is see if the autoclave, which is used for sterilization, is effectively killing all microorganisms and spores. We generally want to use highly resistant organisms that aren't found in the mouth, such as the Geobacillus or Bacillus species. And if these organisms are able to be killed in the sterilization cycle, it means that the less resistant microorganisms that might be found on the equipment will have been killed. Generally, we want to do these tests weekly, making B our correct answer. In addition to the weekly spore tests, which are known as biological tests, we should also do mechanical and chemical tests, and these two should be performed more frequently, with mechanical monitoring at every load and chemical monitoring inside every package. So if a biological spore test has failed, then the instruments need to be recalled and quarantined, and the spore test must be performed again. If it returns negative, then it can be used, but if it returns positive again, then the sterilizer should be taken out of service until repaired. So if we take a look at the other options, we know that they are mostly incorrect, as we do not need to be doing biological tests that frequently, so A is incorrect, as we are using a combination of the mechanical and chemical tests in every load. C reads monthly, and this answer is also incorrect, as it is too long to wait to conduct a spore test. If there was an issue with the autoclave, then there'd be too many improperly sterilized instruments that were being used, so this does pose a risk of transmission to the patient and to the healthcare provider. D reads yearly, and this is also too long of a time to wait before doing the spore test, so this makes this answer incorrect as well. So now we know that we should be doing a spore test weekly.
So question 1 reads, what is the patient's blood pressure category? So for this question, we immediately refer to the patient box given, and we see a reading of 131/90. So we refer to the blood pressure category table, and we see that a normal blood pressure is measured as anything less than 120 systolic and less than 80 diastolic. So that would leave option D incorrect. Next, we have elevated, which is the systolic measurement of 120 to 129 and a diastolic measurement of less than 80. So that would leave option A incorrect. Next, we have hypertension stage 1, which is measured as 130 to 139 systolic, or a measurement of 80 to 89 diastolic. So since you always take the more severe reading, and considering our diastolic measurement is over 90 and not the 80 to 89 seen in hypertension stage 1, that would leave hypertension stage 1 incorrect and option B incorrect. So hypertension stage 2 is measured as 140 and above systolic, or a measurement of 90 and above diastolic. We also have hypertensive crisis, which is 180 and above systolic, and or a diastolic measurement of 120 and above. So those readings are way too high, and that makes option E incorrect and leaves us with option C. So since our diastolic pressure is 90 and hypertension stage 2 has a diastolic pressure of 90 and above, that would make option C, hypertension stage 2, correct.
Question 37 states, each of the following is a valid statement on the use of latex gloves in dentistry except one. Which is the exception? So A states that latex gloves contain certain proteins which may provoke an allergic reaction in susceptible persons. And this is true. It's pretty widely known that some individuals are allergic to latex gloves. So A is not an exception here and can be crossed off the list. Looking at C, it states that oil-based hand lotions can compromise the integrity of latex gloves. This is also true, and individuals should not be wearing oil-based hand lotions when wearing latex gloves to ensure that their hands are kept safe during the work that they do. So C is not the exception and can be crossed off the list. Next, we're looking at option choice D. People with spina bifida are sensitive to the use of latex gloves. Individuals who have this condition are sensitive to the use of latex gloves, and so this statement is true and therefore not the exception. So lastly, we're looking at option choice B. It states, the US FDA recommends using powdered latex gloves only when absolutely essential. Now, it is the latter part of this statement that is incorrect, because the use of powdered latex gloves is absolutely not allowed. The FDA did ban their use in 2017, and the reason for this was because individuals had allergic outcomes to the powder, and so the combination of powder and latex is just a little bit too much. So these are banned, and that leaves us with option choice B as being the correct answer choice here, as it is the exception.
Question 3 asks us, what is the recommended age to receive the first dose of human papillomavirus vaccine? So what we know about HPV is that it's a group of viruses that cause warts on different parts of your body depending on the strain. But luckily, there are available vaccines that protect us against it. So there are vaccines that protect us against 2, 4, or 9 HPV types, but all vaccines protect us against HPV types 16 and 18, which carry the greatest risk of causing cervical cancer. So for this question, it's important to know that CDC, or the Center for Disease Control, recommends children ages 11 to 12 to get the doses of HPV vaccine, and the second dose 6 to 12 months after. So looking at the question and with the information we've just learned, we know that it wouldn't be option A, B, or D, but instead option C, 11 to 12 years.
Question 38 states, each of the following is necessary for a company's dental floss to qualify for the American Dental Association, or ADA, seal of acceptance except one, which is the exception. So A states, using the floss in conjunction with brushing is more effective at plaque reduction than brushing alone. This is going to be very important because it shows that by using the floss, it's going to be an additional supplemental tool to promote one's oral health. So A is not the exception to the rule and can be crossed off. B states, all components of the floss are safe to use inside the mouth. It's crucial that all aspects of the floss are safe for individuals to use. So B is incorrect as it's not the exception to the rule. C states, unsupervised use of the product by an average patient will do no harm. Now this is also going to be important as it ensures practical use of the product and that someone is able to use it without too much instruction or any other supports. So C is incorrect as it is also not the exception here. So D here is something that's going to be expanded on in a bit more detail. So let's say that we have a dental floss that was previously accepted by the ADA Council on Scientific Affairs, and now there's a newer manual product that exists, and it has a similar design and similar composition to the pre-existing dental floss that was already accepted by the ADA Council on Scientific Affairs. The manual product will already have the ADA seal of acceptance with regards to these different aspects, and there's really no need for there to be any clinical trials to show efficacy and safety because the efficacy and safety has already been shown to exist in this previous dental floss that was already existed and went through that process. Therefore, D is the correct option as it is the exception to the rule, and C
Question 4 asks us, what type of hypersensitivity does contact dermatitis fall under? So we know a hypersensitivity reaction is the body's extreme immune response to an antigen, and we have 4 different types: hypersensitivity 1, 2, 3, and 4. So type 1 is a reaction mediated by IgE antibodies, and it causes localized and systemic anaphylaxis, seasonal allergies, food allergies, hives, and eczema. So no contact dermatitis, making option A incorrect. So type 2 is a cytotoxic reaction mediated by Question 4 asks us, what type of hypersensitivity does contact dermatitis fall under? So we know a hypersensitivity reaction is the body's extreme immune response to an antigen, and we have 4 different types: hypersensitivity 1, 2, 3, and 4. So type 1 is a reaction mediated by IgE antibodies, and it causes localized and systemic anaphylaxis, seasonal allergies, food allergies, hives, and eczema. So no contact dermatitis, making option A incorrect. So type 2 is a cytotoxic reaction mediated by IgG or IgM antibodies. Here, red blood cells are destroyed by complement and antibodies during a transfusion of mismatched blood types, or even during erythroblastosis fetalis. So this tells us option B is the incorrect answer for this question. Type 3 is a reaction mediated by immune complexes, and it's known as immune complex-mediated hypersensitivity. Its forms are seen in glomerulonephritis, rheumatoid arthritis, and systemic lupus erythematosus, making option C incorrect. Type 4 is a cell-mediated hypersensitivity. It's a delayed reaction, and its most common form is contact dermatitis, tuberculin reaction, autoimmune diseases such as diabetes type 1, multiple sclerosis, and rheumatoid arthritis. So seeing that we see contact dermatitis in type 4, that would make option D correct.